Hi guys, welcome to the 2021 problem-based learning talk show. I am Irisa from Zhongshan Medical University. My topic today would be about polycystic ovary syndrome. So, what is polycystic ovary syndrome? If we actually break down the word polycystic, the prefix poly means many or multiple. Cyst refers to cysts, and the suffix -ig means pertaining to. So what this condition is a syndrome of many or multiple cysts in the ovaries. We're going to talk about what this condition is and some of its clinical features, and also we would discuss the methods of diagnosis and ways to treat it. All of the above information could be easily found in Clinical Key Student, in detail or in summaries. Moreover, the Clinical Key app works perfectly on the phone, which is why Clinical Key has always been my first go-to when it comes to looking out for credible and reliable medical information. So, here's our patient. You should call her Emma. So this Emma girl, she was a 23-year-old young woman with zero gravidity and parity. Presents to the office with complaints of irregular menstrual cycles. Upon further questioning, she has also noticed an increase in facial hair and acne for many years. On physical exam, even though her blood pressure, pulse, respiratory rate, and temperature are quite normal, she is obese with a body mass index BMI of 34 kilograms per meter squared. And she is noted to have some hirsutism and acanthosis nigricans within her neck and inner thighs. So, when it comes to the diagnosis, we should always consider PCOS in any reproductive aged woman, especially those who has clinical signs of irregular menstrual cycles or hyperandrogen. So, what are the other clinical signs? This includes menstrual cycle irregularities. Oftentimes, majority of the cases of PCOS have functional ovarian hyperandrogenism, which means their ovaries produces excess male sex hormone. These excess androgen could lead to altered and added gonadotropin levels. Oftentimes, it can inhibit or prohibit ovulations, so your menstrual cycles could sometimes be delayed or irregular. With menstrual irregularities, we may see oligomenoria, which is less than 9 cycles per year. Or you could have completely amenorrhea, which means you're not having any periods at all. The second category of clinical features also relates to that high level of androgen, so hyperandrogenism. So hyper just means high or above of. Hyperandrogenism leads to characteristic findings that we see in patients with PCOS. One of them is acne vulgaris. They also have issues with hirsutism or excessive hair growth. In the picture showed on the right, we could see hirsutism in the beard area of the patient. The third component, also a risk factor, and that is being overweight or obese. And the fourth factor we're going to talk about is actually the polycystic ovaries itself. After all, this is polycystic ovary syndrome. So, after we have learned the clinical symptoms, it won't be too hard to tell that our patient Emma presents a strong sign of PCOS. For suspected PCOS patients, further lab tests are needed. It's important to recognize that PCOS is a diagnosis of exclusion, which means that we have to rule out or exclude many other conditions that could be causing some of the signs and symptoms which we have just discussed. So, one of the first things you want to do is you want to do a urine pregnancy test, UPT, or a beta-HCG test. And if either of these are positive, that means your patient might be pregnant. So you want to rule a pregnancy because pregnancy could cause amenorrhea as well. As for our patient Emma, she is a 23-year-old young woman with zero gravidity and parity, so we could simply exclude the possibility of pregnancy. Furthermore, there's the TSH or thyroid-stimulating hormones to see if this patient have thyroid diseases. And also the prolactin levels for hyperprolactinemia. Next, FSH or follicle-stimulating hormones, the luteinizing hormones or LH, and estrogen levels. They help us rule out hypogonadotropic hypogonadism. Then, it's 17-hydroxyprogesterone to see if these patients have what we call non-classical congenital adrenal hyperplasia. This condition on CCAH can actually mimic PCOS quite a bit, so it's important to rule out this condition. And last but not least, their androgen level. So, since hyperandrogenism could be characteristic features of PCOS, it could still be caused by other factors. For example, an androgen-secreting tumor. So, now that we have known that it's important to exclude disorders that mimic PCOS, we should take a look at the blood test results of our patients. So as Emma's test shows, we could see that the TSH, prolactin levels, and the connectional hormones are at rather normal levels. Hence now, we're able to cross out the possibilities and disorders mentioned above. Thank you very much. So now, let's pay attention to the results we've got from the ultrasound. As the chart said, there are cysts on both ovaries, and the right ovary was at an abnormal size. This brings us to our next part of the diagnosis. So, keep in mind that PCOS is a diagnosis of exclusion. Once we have excluded other causes, we can then use what we call Rotterdam criteria. So, there are actually three components of the criteria. The first is having clinical signs or laboratory symptoms of hyperandrogen. If they have either of those, that's 1 point of the criteria. The second is having menstrual irregularity. So that is being amenorrhea or oligomenorrhea. And the third part of the Rotterdam criteria is polycystic ovaries. And the best test to assess whether a patient has polycystic ovaries is to do a transvaginal ultrasound. So, this brings us to our conclusion. To meet the Rotterdam criteria for a diagnosis of PCOS, you have to have 2 or more of these signs. And here, as the case of our patient, the diagnosis is made. Now that we have made the diagnosis, how do we treat PCOS? The first part of our treatment is actually lifestyle modification. Well, that's not a surprise at all, is it? We all know that it's very important to have a diet. So, a calorie-restricted diet, a low-carb diet, and also exercise. And, in fact, if you have extremely good lifestyle modification, this could lead to improvement in menstrual cycles. And if at least 5 to 10% of your weight has been lost, those signs and symptoms related to hyperandrogen would significantly improve. And yeah, it might seem just too easy for some, and they would probably consider what I just said as BS. But what I have to say is that all of the information provided to you comes from the Clinically Key Student Database, and all of the information is backed up by scientific researchers. Want to see it yourself? Simply join Clinically Key Student. Enter your question, and voila! You're now a know-it-all yourself. Congratulations! Okay, back to the treatment. After the lifestyle modification, we would use what we call combined oral contraceptives, COCs. This is a first-line treatment that helps treat many parts of PCOS. In fact, one of those is menstrual cycles irregularities, and it also helps treat acne and hirsutism. The second area we're going to talk about is treat hyperandrogenism. As I mentioned in COCs, they can be used to treat symptoms like acne and hirsutism. But after a while, often months, if you no longer see improvements, we move to treatments of hyperandrogenism specifically. The next category is about associated conditions with PCOS. For example, obesity, metabolic syndromes, and impaired glucose tolerance. They are all associated with PCOS. So metformin is actually a very important treatment, especially for patients who have type 2 diabetes. In a way, since metformin is often used as the first line for patients with type 2 diabetes, we use metformin here as well to improve their insulin sensitivity and glucose tolerance. So, what is polycystic ovary syndrome? We've discussed its symptoms, diagnosis, and also the treatments. I hope everyone finds this case interesting and informative. Truly appreciate your attention. But there's one last thing. Make sure you try out Clinical Key Student as well as Complete Anatomy. Thank you.